Good afternoon, everybody, and thank you for joining us for today's webinar. It's fantastic to see so many of you already conversing in the chat and to see so many of you logging in from all over the world and across Canada. So thank you so much for being here today. Bonjour à tous et merci de vous être joints à nous. My name is Meredith Dalt. I work in external relations and communications here at the MCC, and I'm going to be your moderator today. So we've got lots to cover. I know you have lots of questions already in the chat, but I want to start with a land acknowledgement because at business meetings in Canada, it's typical that we start with acknowledging the fact that we live and work on Indigenous lands. And so we do this in the spirit of reconciliation. And so today, I want to begin by acknowledging that the Medical Council of Canada, which is in Ottawa, Ontario, is situated on the territory of the Anishinaabe Algonquin Nation, who continues to care for and sustain the land on which we gather, work, and play. So before I introduce today's panelists, which I know you're keen to get to, I want to do a little bit of housekeeping. First thing is that today's webinar is taking place in English. Le webinaire d'aujourd'hui se déroule en anglais, mais vous pouvez poser des questions en français, mais les réponses seront en anglais. You can ask your questions in English or French, but all the questions are going to be answered by the panel in English. That said, just by signing up for today's session, you're going to be receiving a recording of this conversation in your inbox. Just keep your eyes on your inbox. We don't promise a date, but it'll be coming soon. We will also be sending a version with French subtitles. So that will be coming soon and for the French speakers. Un enregistrement avec traduction en français sera disponible après l'événement. Okay? So, other important things. You seem to have the hang of the chat and the Q&A already, but I just want to clarify. So the chat is your space. That's for you guys to converse with each other. That is not the place to ask questions of the panel. If you have a question that you want to ask to the panel, that must go in the Q&A box only, because the panel are not going to be reviewing the chat. That's your space. That said, I really encourage you to keep your conversations civil, respectful, and in these challenging times, kind. So without further ado, here we go. I'm going to introduce today's panel. Our first speaker, Dr. Viren Naik, is the Chief Executive Officer of the Medical Council of Canada. In this role, he leads the MCC in its mission to serve as a trusted keeper of physician credentials and as an assessor of physicians' general competencies in order to inform safe licensure decisions. Dr. Naik is a professor of anesthesiology at the University of Ottawa and has more than 25 years of experience as an educator, researcher, and leader. In 2009, he was recruited from the University of Toronto to establish the University of Ottawa Skills and Simulation Center as the founding medical director. 5 years later, while completing his executive MBA, it's an impressive CV, Dr. Naik, he then served as the Vice President Education for the Ottawa Hospital, one of the busiest academic health sciences centers in Canada. He has also served as the Director of Assessment for the Royal College of Physicians and Surgeons of Canada, overseeing the credentialing and examinations for all specialties in Canada. It's really great to have you on this call, so thank you very much for being here. Stephanie Price is the Executive Director of the Federation of Medical Regulatory Authorities of Canada, or FEMRAC, where she oversees initiatives to ensure the effective regulation of medical practices across Canada. With extensive experience in regulatory policy, Ms. Price is dedicated to fostering collaboration among Canada's provincial and territorial regulatory authorities. A licensed engineer who has worked in provincial and professional regulation since 2009, Ms. Price has also served as the Executive Vice President of Regulatory Affairs at Engineers Canada. Thank you for being with us today, Stephanie. And finally, Dr. Filipe Santos, some of you will know him already, arrived in Canada in 2017 after completing medical school, his residency training, and his PhD in pharmacology in Brazil. After completing a 2-year clinical fellowship program in anesthesia education and simulation at the University of Toronto, he then earned a Master of Science in Community Health, also from U of T. A board-certified anesthesiologist, Dr. Santos serves as an assistant professor and simulation lead at the Department of Anesthesiology and Pain Medicine at the University of Toronto. Dedicated to supporting and mentoring other international medical graduates, Dr. Santos has a unique perspective to share from both his own lived experience as an IMG and from what he has learned supporting others on their journey. Thank you so much for being with us today, Filipe.
Thank you.
So you guys are all unmuted and ready to go. Viren, I want to start with you. So let's kick off today's discussion just to make sure we're kind of we sort of understand which space you guys are each working in. So Viren, very high level, what's your role at the Medical Council of Canada when it comes to supporting international medical graduates, or IMGs?
Well, thanks, Meredith. And again, I want to thank you and the entire team in the background for all of this heavy lifting in this our first webinar. And I think that, this starts with that. Is here we are at our first webinar being hosted by the Medical Council of Canada, and hopefully not our last webinar, because we are committed to bringing the information to the people who can use it best. So thank you. And I also, as CEO of the Medical Council of Canada, I want to thank my co-presenters for joining us on this journey today, Stephanie and Filipe. I think the reality, I don't have to let anyone who is in Canada know that one out of four or one out of five Canadians don't have a primary care physician, and healthcare is really in crisis, I think, in Canada. And there's lots of reasons for that, especially post-COVID. We have an increasing population, increasing burden of disease, increasing wait lists. But the reality is, we also saw a loss of healthcare workers in our workforce from burnout and other wellness issues in this post-COVID era. So, I think what we have to recognize as a country is that Canada has always depended on IMGs and ITPs. It's always been a big part of our physician workforce, and I'm proud of that as a Canadian because Canada, I think, has always been a country that it welcomes immigration and welcomes all the diversity that comes from that immigration. So first, I want to say to all the physicians out there, thank you for wanting to contribute to our healthcare and to serve patients. And I know that journey is not always easy, and that's part of why we're here on this webinar today. But thank you for your resilience in trying to do that. The Medical Council has always been involved with IMGs. I think we are sort of often that first checkpoint when people are getting serious about coming to Canada. But maybe we haven't been so explicit about how involved we are with IMGs and ITPs. And when I say ITPs, internationally trained physicians, which are a little nuanced from IMGs. And we did a new strategic plan almost a year ago now, and the reality, without getting into the details of it, is while we continue to serve the Canadian education system, we're going to have a special focus on certainly in the next several years around IMGs and ITPs. And as Meredith, you said that we're the trusted assessor of credentials and assessor of a physician's general competencies. I think that's not just about the exams, which we all love to hate, so to speak, but it really, I think, is about trying to help on that end-to-end journey. I think the reality is we have to go upstream and help people understand what it means to come to Canada, what practice in Canada is like, and then when we hope they realize that Canada is a destination of choice, and I really do believe that as a proud Canadian, that then we have to help them navigate, I think what are complex pathways, depending on your education, depending on the discipline you're trained in, depending on the country where that's all happened, then even what you're interested in doing in Canada. Maybe it's about practicing in your discipline, practicing in another discipline. And then the reality is, and Stephanie will speak more about this, is that every province is a little bit different as well in terms of its approach to things. So our hope is to untangle some of that. I can tell you that that's one of the reasons that we look to experts like Filipe here to help us untangle that. And then, of course, we want to also have set people up to be successful on the exams that are sometimes an evil necessity, but an important necessity for safety, and help them be successful in that and then successful into their practice. I'll just close, Meredith, by iterating. We've also refreshed our values, and the two values that I want to make clear in the MCC going forward is one is inclusion and belonging. We can not talk about being about IMGs and having a focus on international graduates without helping and bringing their voice to the table. And we're committed to doing that across the Medical Council of Canada, Filipe being one of those voices, but many other voices at all levels in our organization. And the second value that I want to make sure this audience knows about is that of transparency. I know these ivory towers can sometimes be viewed as black boxes that you don't really understand why or how things are done. And, we're committed to unpacking that. We're committed to being in front of people like this, like we're doing today, and other forums, and doing our best to be as transparent as possible. And I'm not going to tell you that we've solved all of that. I'm not going to tell you that it's every answer is going to be answered today, but I am going to tell you that we're absolutely committed to this journey and committed to all of you.
Fantastic. And the audience is here for it because we're already at over 2,000 participants on the call today. So I just want to flag that for the audience who are throwing questions like mad into the chat box. So we have an hour and a half. We're going to roll along and do the best we can to support our audience. But thank you for that, Dr. Naik. Stephanie, can you tell us a little bit about what FEMRAC does, the Federation of Medical Regulatory Authorities? I know you don't work directly with IMGs, but you also play an important role in supporting them. So can you give us kind of a high-level overview?
Sure. So FEMRAC is exactly what the name says. It's a federation of the medical regulatory authorities, those organizations in every province and territory across Canada who license and regulate doctors. It's them, the medical regulatory authorities, who work directly with all of their applicants, including IMGs, and what we call the registrants, the doctors who are licensed to practice. So FEMRAC's role is to help all of them come together to exchange information and to work on issues of common concern. And right now, that does include expanding pathways to licensure, facilitating the mobility of doctors in Canada so they can move between provinces, and making sure that we rise to this moment, because there's no doubt, like Dr. Naik was just saying, we do have problems and we do need to address them, and we need to work together to do that. So we're really big on collaboration with all of those medical regulatory authorities and with other organizations like the MCC. So because we're located here in Ottawa, we also act as their voice with the federal government and any other national bodies who are around. Meredith, do I have time to tell people a bit about regulation?
Yeah, I would actually love it if you would, just so that we're all on the same, we're on a level. This is the first question you each get to have a little more grandstanding. Let's go.
All right. So regulation is important in Canada, and it's different in Canada. So every single province and territory has its own regulations for medicine. They have a piece of legislation that defines what the job of the medical regulatory authority is. And regulators are an important part of the system because they're the ones who make sure that doctors perform safely, competently, and ethically. It's their job to protect the public in respect to the practice of medicine. So that means they put the public interest first. They do not put the interest of physicians first. They don't just license doctors. Once they're licensed, they also receive and investigate complaints. They create practice standards for doctors that define what good practice looks like. They make sure that doctors maintain their competence through things like continuing professional development programs and practice reviews. And they are the ones who make sure that day to day, the care that's delivered in Canada is up to high standards. It's slightly different in every region, which is what makes it challenging. And it's a very Canadian thing. We see this in all of our professions. It means that here in Ottawa at FEMRAC, I have no authority. There's no legislation in Ottawa that lets FEMRAC say what regulators should do. They have complete authority to make their own decisions, make their own rules, make their own processes, and they do vary. And I know we're going to talk a lot about that today. But at the root, they're all doing the same thing. They're making sure that doctors perform well for the safety of all Canadians.
That's great background. So I hope that's helpful for the audience just to sort of set the scene. Filipe, your turn. As we heard in the introduction, you are joining us in a slightly different capacity because you are an internationally trained or international medical graduate who's now working as a doctor in Canada. Can you tell us a little bit about your own journey just so we have a sense of where you're coming at this from?
Yes, thank you so much. It's a pleasure to be here. I would never imagine in a million years that I would be here today, but I came to Canada in 2017, and like many of the IMGs that are watching here, I just had a dream of staying in Canada as a physician. And I remember on my interview to be hired at U of T that I said that after they asked me what I thought after 3 years that it would be my goal. And I said that my goal is to feel like everybody else, that it was equal to all the other anesthesiologists. And I think that you know, coming from like outside of Canada and being able to stay here is really important to show to other people that they can also do it. Like everybody that's watching here, there is a pathway. There's many pathways. We're trying to detangle the process. And I think it's a matter of trying to find what's the right pathway for you. You know, the fact that there's each province has a different process can be a problem because it's very different and there's many pathways. But on the other hand, if you want to see it from a positive lens, it gives us also many opportunities. There's opportunities for everyone in different provinces, in different areas, and different pathways. So I hope that I want to bring to people my perspective from the sense of I did this and you can do it also. I'm not better than anyone else here and anyone watching me. It's just a matter of being resilient and knowing the process, understanding, and going after what you really want to achieve.
I've talked to you in the past about this, and one thing you've said is that since you started your process, so 2017, you've seen a huge change even in the IMG experience. Do you want to just briefly sort of talk about the kinds of positive changes you've seen, as rigorous as the process is still for many people?
Absolutely. So there has been so many changes. In 2021, for example, the Royal College allowed physicians to apply for the Royal College exams without having any previous experience in Canada. And that was innovative. When I was looking into this back in 2013, when I was still doing residency, you had to practice 2 years in Canada before you could challenge the exams. Now, this is not a requirement anymore. Right after, they also waived the requirement of having 5 years of experience as a specialist in your home country. So people that just finished residency would be able to still apply for the Royal College exams here. And then afterwards, other changes starting coming through. The MCC didn't require the MCC QE2 anymore and made everybody's life easier getting LMCC. So a lot of people like me, I had passed MQE1. I didn't have to take the QE2 due to that change, which was a positive change for IMGs. So I think there's lots happening. More recently in 2023 and 2024, we can mention how the provinces in the Atlantic are now taking specialists that have the eligibility for the Royal College exam but haven't taken the exam yet. Nova Scotia has been innovative and really one of the first provinces to bring some new concepts to licensing, such as, for example, they accept people that have full license in New Zealand, Australia, or Ireland, or UK to be able to get a defined license in Nova Scotia. And this was innovative and really, really thoughtful of them to try to speed up the process of licensing of IMGs. So I think that, and finally, I just want to mention how Ontario has innovated with their PRA program, where they were the first province to start accepting clinical assistant, licensed clinical assistant jobs to break a gap. And this is a huge, huge problem for MGs that have gaps, and being able to allow clinical assistant jobs to break a gap and enable people to participate in practice ready programs in Ontario after having done licensed clinical assistant jobs in Ontario was groundbreaking to me looking at this process. So I think the other thing that Ontario did that is very interesting is that they also accept up to 240 hours of telemedicine to count as currency of practice. So this was innovative and is the only province that has an explicit mention to telemedicine on their requirements for practice ready assessment. So I think each province is trying to improve their pathways. We have seen multiple changes since 2021. I highlighted just a few. I think there's no single province that has, I think I can mention different things each province has done to improve. Saskatchewan, for example, has a program that you apply for the practice ready assessment kind of like alongside with immigration pathways for a permanent residency. So I think each province has done their best to try to increase the options for IMGs. And I think that is what the message we want to get across is that we like Canada is interested in IMGs. There are rules, there are pathways, there are criteria that needs to be met, but you know, everybody's working towards a common goal, which is to allow competent physicians to deliver care for Canadians. And I think that's what all provinces are interested in. And as IMGs, instead of just, seeing the negative in things, we need to kind of shift a little bit the mindset and understand that there are processes in place and that there has been so many changes in the last 4 years that in the last 20 years have not happened. Like, so we are absolutely in a new era for IMGs in Canada. I can say that
Well,
without a doubt.
Yeah.
That's
And
encouraging.
oh,
Go
Meredith,
ahead.
can I jump in on that one?
Yeah, yeah.
Just as, and I might ask Stephanie to jump in as well. Filipe, you said it well, and I want to stress that even on this webinar, what we're telling you today, it might be different by tomorrow. I used to think that these changes, okay, well, we're going to do a webinar today, and this is the way it's going to be for the next 6 months. So everything that we're saying is gospel for the next 6 months, but I've actually changed to saying that things are changing daily, even. And so, we're doing our best to tell you what today is, but tomorrow could be very different. And I'll lean on Stephanie as well, because the two of us are often on point to how rapid these changes are coming.
Yeah, I mean, Vern, there's not a meeting I go to with the medical regulatory authorities. I'm trying hard, Meredith, not to use the acronyms, but there's not a meeting I go to where I don't hear about someone who is creating a new pathway or, working with their government to create one, working with their health authority to create one. And they are looking for ways to do better. And it really is from the biggest to the smallest. I don't think there are any exceptions to that. Different things are happening in different places and different timelines, but and makes it hard. It makes it hard for me, right, to stay up to date, and that's my full-time job. So I understand exactly what you're saying, Filipe, about, we have to detangle this and try and figure out what the right pathway is for each individual. And that takes some digging to do it. But the good news is it's getting better all the time, right? So there are going to be more pathways in 6 months than exist today. I know that for a fact because I know some of them that are in the works right now, right? And so we have to be hopeful about that, I think, and be glad that we're here in this time when those pathways are being expanded.
One of the important changes that I forgot to mention is just want to briefly mention, Meredith, is that before subspecialists that were allowed to take the subspecialty exam in Canada, if they didn't have certification in their primary specialty, they weren't able to get licensed. And now basically in every single province, I think except New Brunswick or Quebec, if I'm not mistaken, but if you have taken your subspecialty board exam, because you did, for example, a subspecialty fellowship in Canada, and you're a subspecialty affiliate of the Royal College, you're able to practice in your subspecialty independently in any province almost in Canada. That's a huge change. And that is like, we're talking about a year and a half ago. Like, so there are people that have this status a long time, like for a while, and weren't able to practice. And now they're able to practice as a subspecialist. So I think, and I mean, and I think that it's important that we understand that these changes come with a lot of thought. Like, they are safe to practice. There are people who did subspecialty training. There are people who underwent testing through their Royal College exam in their subspecialty. They are completely competent and able to provide care for the Canadians. And I think we are just, it's a matter of the medical regulatory authorities along with academic centers and the MCC trying to find ways of understanding who are the competent physicians that are enabled to provide care for Canadians. And I think that, the focus shifting to IMGs as it has been politically and because of the need as well, we have come to innovative solutions, and it's interesting because each province will come up with solutions that you will look at it and you say, like, this makes so much sense. How did you not think about this before? But that's how change happens. You need a political pressure. You need a political moment aligned with the availability of examinations, of regulations, and all this comes together. And I think we're seeing so many new pathways that it's truly exciting to me. The day that Ontario announced that they're accepting the PER route, I was like ecstatic. I was in Brazil and I almost lost my flight because I had to post it live. I had to tell people about it because I'm on this all the time. Like, this is like, I was waiting for that news for 4 years, literally. So, it's all these changes that are happening. And I think, everybody's working toward this, but I think IMGs need to be mindful that practicing medicine is very high stakes. We're taking care of people's health. We're taking care of people's lives. We can't simply, make blanket, rules that would allow physicians that are not competent to provide care for Canadians. And I think that the work that medical regulatory authorities with MCC have done is outstanding. And I'm just extremely happy to see that the changes are coming, and the changes are still allowing safe practice. Like the physicians that are competent are being more and more integrated into the Canadian healthcare system, which is ultimately what we want. We want the physicians that are competent to provide care for Canadians. And I think that is actually happening at a rapid speed that we have not seen in the last 10 or 20 years. That's for sure.
Unsurprisingly, can I just say, we have more questions now than we could answer the rest of the questions that came up just now, like to the end of this evening. I know, Stephanie, you wanted to jump in there, but I do also want to make sure, I want to make sure that everyone's kind of clear on what the most common pathways are. We keep talking about the most common pathways. I don't know, our audience is coming to us today from all sorts of different backgrounds, and can we level the playing field with a bit of a let's just walk quickly through what are the most common pathways in Canada. Viren, do you want to take this?
Yeah, let me
one?
start, and then Filipe can tell me what I got right or wrong because there's so many. But I think first and foremost, there are some countries that have jurisdictional recognition from both the Family Physicians College as well as the Royal College. And certainly with the Royal College coming from training where it was in a jurisdictional pathway with, some assessment of substantial equivalence allows you to sit the examinations and move on to full licensure. For those not from those countries that have been assessed for those substantial equivalents, there are the most common pathway in the past, quite frankly, was trying to go through the CARMS match to repeat residency training here in Canada. And, I think that still is a viable pathway and an access pathway. And I don't want to say that that's an irrelevant pathway because for some people, as Filipe has said, their training might have been different. Maybe they want to go through the Canadian training system. And in doing so, yes, again, you would come through the Medical Council of Canada, and there are a set of exams, both our QE1 and our NAC, that are part of the selection process in going through the CARMS match. The reality, though, is that, there are limited positions for international medical graduates and trained physicians. There is government planning to expand the number of residency positions, and Stephanie knows very well that the government is working with our universities to get that established. But even with expansion, there's still more people who want to serve Canadians than I think we have residency positions. And I also, wonder at times if a person has practiced, has been certified in their country and certainly practiced in a discipline, and if there isn't new things to learn by going through an entire residency program in Canada, if there are other ways to get them to practice. And so we have almost a decade of experience in stewarding with the different provincial PRA practice ready assessment programs, more workplace-based assessment strategies to move people to essentially assess them with the professional authenticity of their knowledge, skills, and attitude, caring for actual patients in a structured program that would move them to having the regulatory authorities feel comfortable to issue a provisional or some sort of license so that they can move on to actually serving Canadians and continuing to develop those competencies. The challenge for that route is, as Filipe has mentioned, is recency of practice, especially for people who've already immigrated to Canada, who've left their practices, and some of the other requirements. And again, some of the innovations that we're talking about is seeing how we could get people recency of practice, like Filipe mentioned, as through clinical is counting clinical assistant, counting fellowships as part of that recency of practice, where in the past those things weren't considered, as well as looking at some of the other requirements and what are the best things to make sure that somebody is set up for success. So the practice ready assessment pathways are expanding. Now they're predominantly around family medicine in most of our provinces, but certainly in some of our provinces, Quebec, Manitoba, Alberta, there also are practice ready assessments for specialists. And then Filipe has as well already mentioned that for specialists particularly, the practice eligibility route of the Royal College is now allowing essentially experience in Canada to be counted towards being eligible for their examinations. And that's, as we said, been a game changer so that it does provide the access for those who want to move through the Royal College. Those are probably the predominant ones, but with many more in development and in flight, with recognition that while most of our current pathways involve examination to some degree, I think we have to be also thoughtful about, which examinations make sense and where, for someone who's been finished a residency training program in another country who, has been practicing for a long period of time in that discipline. Is our QE1 examination, the most appropriate examination for them to write if the plan is for them to practice in that discipline? And so these are all things that are under consideration.
Okay, good to know. Anyone else want to jump in? Or, I mean, it was quite thorough.
I'll ask Filipe. I did my best. I'm a pretend expert. Filipe is our real expert in this space, and then maybe Stephanie wants to speak about some of that as well.
Quickly
Filipe,
address
did I get it more or less right?
Yes, you did.
one of the questions we often hear is why does it take so long? I mean, you walked us through kind of various pathways, but why does it take so long? People are saying.
Filipe, why don't you start?
License or
And,
the results?
Oh no, not the results. To get the license, like to be able to practice in Canada. Why?
Sure. Well, I'll start and then I'll turn to Filipe. I mean, there are and there are definitely some requirements that require some periods of practice in Canada, like practice eligibility routes, and so those take longer. But I think what really is the thing that gives our candidates indigestion is, their credentials being assessed. And, we here at the Medical Council of Canada certainly manage the credentials assessment for most of the country. And what I'll say is that, and I hope that people understand, is part of that credentials assessment is one, I know it's none of the, what are we at now, 2,300 people on this call. But, the reality is that we actually do need to make sure that the person applying is the person. So a little bit of identity validation as you would need to do in any thing. And, those things are pretty rapid. But the thing that can take a bit of a long time is the credential validation, the validation of the certificates, of the training, of the residencies. And, again, while we do trust everyone, we engage in a process with a partner in source validation. So essentially going to the schools and double checking that the certificates being submitted and the credentials being submitted are legitimate. And, the reality is all that happens pretty quick, but we depend on the schools to get the information back to us. And, the reality is that the return of those validations from the schools can be highly variable. Now, in our commitment to transparency, we're working on our systems so that candidates will understand, and this isn't going to happen overnight, but we hope in the next year, candidates will understand where in the pathway they are, so that they know that it's not because we haven't opened their documents here at the MCC, because that's never the case. They'll see where they are in the pathway of their credential validation, and so that if what we're waiting on is the return from the schools, they'll know that that's where the bottleneck is. And I think a lot of the frustration is not knowing where you are on that journey, and so we're committed to making that more transparent.
Thank you.
I don't know, Stephanie, did you have anything to add to that in the licensure?
Not my area of expertise, in particular on the timing. But I want to know how Filipe grades you, if you did a good enough job
If I did
describing
it
the
okay
major
on that one
pathways.
too?
Yeah.
Yeah, exactly.
No, I think that a lot of the problem related to timing comes to organization because currently, and this is something I will tell Viren, but I already had told Viren, is that, unfortunately, we are not able to access certain exams all throughout the whole year. There's a lot of planning that needs to go around for you to have NAC to happen, and then that exam, as well as the results for the QE1, takes time to, especially before where we had the short answers. Now this is going to be a change for 2025. I think there were a lot of issues that took a while to get the results, and all this for IMGs is like it's counting time out of currency of practice, which will bite them afterwards, So what I try to tell people, all the MGs that I'm trying to help, is that you need to try to create a timeline where you try to organize how you are going to take the exams and meet the requirements of the chosen pathway that you decided is best for you in a way that will keep your gap at a minimum. And to do that, you sometimes need to start by seeing when it's feasible to take certain examinations, because we can't change when those examinations happen, but you can organize yourself around them. Such as, for example, that you'll take one or the other before. You don't need to have the QE1 to take NAC. You don't need to have NAC to take the QE1. So you can organize yourself in a way that the timeline decreases your time out of practice. And this is the main issue that most of the MGs that I talk to have, which is, how do I break my gap? And I think that it's like, it's like in health, like all of you are doctors, all people watching me, and prevention is the best measure is always best than treating something after, right? So preventing a gap is always way better than trying to address it later. And a lot of people are like, what's a gap? So gap is basically when you're not practicing medicine, either as an independent physician, so as the most responsible physician, where you are in a clinical role that requires you to have a license in that jurisdiction anywhere in the world, and that you don't need to be under supervision. So you're able to manage, diagnose, and treat patients independently. Either that, or you are in an official accredited program, such as a residency or a fellowship program. So if you're not training towards a specialty or towards a subspecialty, or you are not practicing independently and you're under direct supervision. Now, we're not talking about those licenses where you are the most responsible physician and there's someone that is doing it, what I call a distant supervision, like chart review. So, we have a lot of licenses that are in Canada considered supervised independent practice, such as defined, restricted, or provisional license. I'm not talking about those ones. So I'm talking about like clinical assistant, where you're not the most responsible physician. When you're in those licenses, you're not practicing independently. So it does count towards what we call gap. So I kind of like to explain to IMGs that gap is the opposite of currency of practice. So if you're not practicing independently, you're not in an accredited program, you are in the gap. And like, what's a gap and how big of a gap is a problem will depend on what pathway you choose. So, certain pathways tend to be a little bit more acceptable in terms of, like, if you apply for a clinical assistant job, you might be able to apply for a license, for example, for a clinical assistant job in Manitoba or Saskatchewan. The gap doesn't matter. But if you're going to apply for an independent license, you need to be into practice. And I get a lot of people saying, like, why is gap like a requirement? And there are many studies showing that, any physician, that includes me or Vern or anyone, if you're out of practice for 5 or 10 years, you're not as competent as what you were before. It's not a matter of who you are. It's just a human thing. If you're not practicing any kind of skills, if you get a musician, if you get a ballerina, if you get someone in sports, if you're 5 or 10 years out of practice, you're not going to perform the same as someone who's been in activity. So I do think that is a matter that needs to be taken in consideration. I never suggested that gap, needs to be waived as a requirement, but I do find that there might be ways of mitigating or allowing IMGs to be able to get that experience while they're in Canada. Currently, basically, it's residency or fellowship that would officially what we call break a gap. However, there has been some changes into how that is assessed, which is, for example, if you are doing a clinical assistant job that is licensed, that is under the purview of a medical regulatory authority, where, you know, if there's a complaint, there will be a body that is supervising that. That will be valued, maybe not equivalent to independent, because it's not equivalent, but at least it will be valued as an experience. And I think that's a change that Ontario started that maybe I'm hoping will increase, but it does depend, like it's a lot of work. You need supervision for the clinical assistant job, and you need a medical regulatory authority that is controlling that license and that practice. Because if you don't have a license, like it is in Ontario right now for clinical assistants, unfortunately, it's impossible to understand how that practice happens, because the heterogeneity of that practice in each area will be too much. It's impossible to know what kind of healthcare you're delivering, how much you're involved in the actual clinical work. So I do think that, you know, licensing clinical assistant jobs, having that regulated really is important, and that allows for IMGs to have a transition towards more independent roles in the future. So maybe they, you know, right now they're clinical assistant supervision, but they're transitioning to practice already in Canada. They're getting to understand the Canadian healthcare system. They're getting to practice in a new language. They're getting to touch patients, you know, in the sense of like doing physical examinations, decide on management with someone who has an independent license as a supervisor. And then they're better prepared to engage into more advanced licenses, such as participating in practice-ready assessments with a much higher likelihood of success, or participating into CARMs or getting a residency position, because they're not coming completely without any base. They're now transitioned into the Canadian healthcare system. So I really think the clinical assistant jobs, when regulated, have a very significant role into the transition of IMGs that are coming to Canada and want in the future to achieve full independent practice.
Yeah, and I'll actually pull on Stephanie here. The clinical assistants do come up as a solution, as a potential solution for the gap, as you say, Filipe. Before I give it to Stephanie, so she can just comment on that, I know the exams often come up and so forth, and again, I want to just stress that some of the changes we made to the exams, like removing the clinical decision-making component and seeing that we can get the same validity with multiple choice, will help us get results to candidates more quickly. And we're doing our best basically to shorten the times. But I liked what you said, Filipe. You know, we're going to do our best on our side, but some of it, as you say, is prevention is the best medicine. And so with Filipe's help, and I see all the heart emojis that come up for Filipe, we're going to work with Filipe to try and you know, give the model timeline, you know, the model prevention, the model, you know, to what and try our best to help you know, basically scope out what is the best pathway to mitigate and minimize that gap as much as possible within the structures that we have, while we work on the structures that we have. Stephanie.
Yeah, Filipe, I'm glad you talked about currency and the skills erosion, because this is something we recently looked at in light of, you know, improvements. Like, what should the policy be? How many years should it be? How much practice should be required? Because, you know, it varies all across the country today. And we're having conversation about, could we standardize on that? And there's very little research or evidence about this. And what we did find out of the UK was showing skill erosion in a matter of months. And so it is a real thing, right? That all of us, as you said, in any profession, we lose those competencies. But having other ways to allow people to practice in a safe and supervised way, like the clinical assistant, is, I think, an important new pathway that, you know, is coming into existence and is being talked about more and more. And so I think that there are, you know, that bar of we're looking for ways to find out who's competent, that is now sort of the vision and the thing that everyone has in their sights. And as we make that more the important goal, then we start to see other ways to allow people to achieve that and to demonstrate that. And I think this is one of the most important barriers that we hear about all the time, right? So it is under discussion. And as you pointed out, things are changing there.
Please mention that to the CPSO now that you're there.
I'll do my best.
I want to make sure that we touch on the subject of exams. There are a lot of questions about exams. Could we go right into exams, Vern? The first, like
Sure,
a
why
question's
not?
coming up again and
Wait,
again.
wait,
is-
let me see. Are there any the opposite of heart emojis as I talk about exams? Because I'm sure I'm going to get them.
Well,
But
One of the standard questions we
there
get
they
is
come. Here they
are
come.
there they are. Why are exams so expensive? We are getting
Yeah,
this question again and again. So look at these
yeah.
guys. They are with
Yeah,
us.
so yeah, there you're with me here, but you know, let me be the first to, if you didn't know, the Medical Council of Canada is a not-for-profit organization. For if anyone was unaware of that, you know, I always say not-for-profit, but also not for loss. I know exams are expensive, and for any of you doing fellowships or maybe something in an academic center, it might not surprise you to learn that whenever you try to do something like an examination or an OSCE in a university, they're expensive endeavors. And I assure you that whatever fees are attached to our examinations, and you know, there's our examinations, and I know there's CFPC examination fees and Royal College examination fees. Just please know that none of this is about putting money in anyone's pocket. This is really to cover the expenses of the exams and the expenses of, you can imagine, the machine that runs our organizations. And I know for some of for the Royal College and the CFPC even, that you know, because they want to try to mitigate the expense of exams, that I know that some of that is done through, you know, their other sources of revenue as well. So they do their best to try and subsidize when there are other significant sources, as do we. As far as you know, as I see some questions that pop up about length of exams, and our question's going to be longer. You know, I think we have always prided ourselves that our QE1 is a clinical exam. And, you know, part of being a clinical exam is making sure that we're presenting clinical scenarios that give a picture of a patient, as opposed to just, you know, how many centimeters is the right upper lobe from the carina for all the doctors on the call. That's not the kind of question we ask. But at the same time, we have an incredible psychometric team here that does its best to really make sure that those questions are fair. We monitor exactly what we think the timing is to read a question and to comprehend the question and to answer the question. And part of the removal of our clinical decision making also allows our exam, which we acknowledge was one of the longest exams that a person might write, to be a much more manageable examination, in you know, 6 to 7 hours, which is more standardized for these kinds of national examinations. So all of those are going to be in play come spring, with the clinical decision making moved, and I hope that, you know, all of that was done for a better candidate experience, both taking the examination and then after the examination. When it comes to OSCEs, we do only offer that twice a year. I know that's Filipe mentioned that, you know, that's why we have to help people understand when they can take the OSCE, and the realities that you don't need to necessarily have your QE1 to take the NAC OSCE. But OSCEs as well, I know it is a pricier exam than our QE1, but the reality again, this isn't for profit in any way. Running an examination with standardized patients and multiple locations across Canada carries the cost that it carries, and we're just trying to offset the costs with the costs that unfortunately our candidates need to bear.
Very quickly, before we leave the subject of exams, tell me, lots of questions coming up in the chat around attempts. I know candidates are limited in the number of attempts they have at each exam. Why is that?
We've done our and we've actually done this work with the College of Family Physicians and the Royal College as well. And really understanding we want our candidates to be successful, and we know that that success doesn't always come on the first attempt. Um, uh, but we also know and have done much analysis as after a certain number of attempts, what's the likelihood of passing an examination? And to be quite honest, a lot of the decisions around the maximum number of attempts is because it didn't feel right to continue to collect examination fees when we had the data that clearly showed that at this point it's unlikely that a person is going to be successful in examination. And that honestly is the underpinning of why these decisions were made. Obviously, there's other things into consideration, but I want to stress to this group on this call that that is the most important consideration, is that we wanted to be fair to candidates and not have them continue to take an examination, continue to pay these fees that we just talked about when the chance of success was negligible.
Right. Anyone want to jump in? No, that's Vern's lane. I'm going to switch course though. I want to make sure there are a lot of confusion and a lot of sort of exhaustion at the provincial systems. The confusion around why can't we just apply one time like in Australia? Stephanie, can I bring you back in here? I mean, we touched on this at the beginning, but like, why is there so much variation between provinces?
Yeah, I mean, there's this really unsatisfying answer, which is it's the Constitution. So, I mean, in Canada, that's our kind of foundational legal act, and it says that the provinces are in charge of education, the provinces are in charge of regulation. And so every single one of them gets to make their own decisions. And I think there are reasons that that still works because there are regional realities that are different, right? Things are different in Newfoundland than they are in BC. And so there are still important things that need to be considered in each jurisdiction, and having a jurisdictional model allows each of the regulators to be able to work with the Ministry of Health in their province and the health authorities, so the hospitals, the medical schools, and kind of concentrate on the needs in that area. But certainly it's frustrating. Like Vern's raising his eyebrows at me, but I've been in this space for a year in medical regulation, and it's very hard for me to figure out what is different and what is the same everywhere. So I understand that frustration. I think one thing that is hopeful news, and it's kind of my job to do this as a federation person, is to tell you that they are collaborating and trying to become more consistent. I think there is a realization that it's really difficult for anyone to be able to understand all those differences. And so there is a desire to be consistent, even though there's no requirement, right? Every one of them could do their own thing and they could do it completely differently and never have a FEMRAC, right? There's no reason I have to exist. And if I don't do well today, maybe I won't tomorrow. But they are trying to share those best practices and be more consistent. And if you think of it from a Canadian's perspective too, like that makes a lot of sense. I should expect the same standard of care wherever I'm going, right? Which should mean the same rules. But it's just not a requirement. And so it happens as not their first priority, but as something further down the list. But it's not ignored, I would say.
So
Yeah.
what's a person to do in terms of thinking about which province do I choose and what to do? Filipe, I feel like you want to jump in here.
Yeah. I think that one of the questions that I get the most is like, what's the best pathway for me? And I think, each physician comes with a unique story. And that when I talk about story, it means not only where they came from, it's where they are able to land in Canada, where they have family, where they have opportunities, who's with them. If you have 3 kids, if you have no kids, if you're single, if you're married, if you like, Newfoundland, if you like BC, there's so many things that come into play that it's impossible for someone to tell you what's the best option. I always tell my clients there's a difference between ideal and real, or what you actually want. But when you look at the provinces, you need to understand that because the requirements are different, your life story might suit or fit better with one province than the other. So for example, I get clients that say, I had a hard time passing the QE1. I feel I'm competent just because it's been a long time. I finished medicine. I passed NAC. What are my opportunities? And then like there's Manitoba, where the QB1 is not as required as NAC is required for many of the pathways. And then there's the opposite. There's people who says, I get really nervous when I do OSCE, but I did really well in my QB1. What are my opportunities? And then I tell them, well, BC and Alberta usually don't require NAC for a lot of their things. So knowing the requirements and understanding that is pivotal to where you're going to go as a province. And I think that one of the things that the MCC and I'm trying to do, and Stephanie's trying to do, and everybody's trying to do, is to try to allow that information to be more transparent, to bring to IMGs what are the requirements in each province, because it's not that the IMGs want to change all the requirements, but we want to understand as an IMG, when we're looking for pathways, we want to know what are the rules so we can try to follow them. And sometimes the rules are not clear. So I think it's a matter of, we do need rules. And I think everybody here agreed on that we, certain exams need to exist. There needs to be a criteria. We need to ensure that, Canadians are treated by competent physicians. And on the other hand, we also want the physicians to understand what is being asked of them. So if there's an exam, there's a clear blueprint, there's a clear understanding what's going to be on the exam. If there's a requirement for a license, we want to understand exactly what are the requirements. Do you need to have permanent residency or not? Do you need to have the QE1 or not? Do you need NAC or not? How many years of experience do you need to have? How do you prove that experience? That is a question I get all the time. And you don't find that information on the medical regulatory authorities. You will find a requirement for independent practice experience, but then they don't tell you exactly how that experience can be proven. So there's a lot of things that I think can improve in terms of communication that doesn't necessarily go around changing the rules, like, changing the current regulations. I think we can do a lot on the current regulations to improve communication, to improve how that information of what is required for each province reaches IMGs so that they can understand what is better for them. And then they put all their effort, all their time and money, because all this costs money, directly into the province that they have more likelihood of succeeding. And as Stephanie mentioned, this is not because, one province is nicer or uglier than the other. It conveys also different regional specificities that are related to their population. There are some populations that have more indigenous populations that have different needs, that requires different kind of care, and they have the medical regulatory authorities that are there for many, many years have come to find what is best, what works best, what selects the most competent physicians for that population. So I think, when you go to the province that you fit best, is basically you are going to the province where you're going to serve best, where you are a better match for the population, and not necessarily because you're better or worse than someone who goes to another province. And I think that's something that we need to a little bit deconstruct, where, because I'm eligible for Alberta and I'm not eligible for Newfoundland, does that mean that, I'm good enough to be a doctor in Alberta, but I'm not good enough to be a doctor in Newfoundland? That's not necessarily true. I just think that, I'm, for example, now competent to practice medicine in Brazil and in Canada, but I would not be competent to practice medicine in China. I don't know their language. I don't know their culture. I wouldn't be a competent physician there. So I think we need to align what we have as a story, what we have as a knowledge, what we have as a competence to where we want to practice. And Canada has 13 different provinces with 13 different cultures and many changes. And I think the medical regulatory authorities know very well what works for their province. So as IMGs, the best we can do is to understand where we are most a better fit, where we can, use our history, our expertise, our competence in a way that will better help the population, and that, the medical regulatory authorities will be very interested in helping you when you meet their needs, because that's ultimately what everybody wants, for competent physicians to help the Canadian population with their different needs and specificities around Canada.
I know
Sorry.
I know, Meredith, I'm not supposed to look at the chat because my ADHD will kick in and I will get confused. But somebody, I did see the question of MCC, please hire Filipe Santos, and I can tell you that in a collaboration with University of Toronto, Filipe will be spending more time with us here at the MCC to help us unravel the mysteries as he's doing here today.
So I wanted to pick up on something you were saying, Filipe, that
Great.
about, it doesn't mean you're not as good a doctor if the pathway in one place, is better for you than another place. I think that's epitomized by the fact that once you are fully licensed here in Canada in one province, you can practice in any other province as long as you have a clean record, right? So you'll need another license, but the medical regulatory authorities trust one another. They believe that all of them are measuring competent physicians in a good and safe way. And so once you have a full license in one province, you can move on to the next one. And so I think that there are, as you said, pathways that work for that province or territory. And quite honestly, they create pathways to meet their needs. And the needs are populations-based, numbers-based, health authority-based, right? There's all sorts of different ways that those needs pop up and are defined. And those are why we're getting all these different pathways. But once you have that full license, and as long as you have, I call it a clean record, but as long as there are no conditions, restrictions, or monitoring, then you're able to apply for a license in another province and it'll be given to you without any further assessment. There's legislation in Canada to make that happen, right? Because we know we have these inefficient borders of provinces and territories. But in the end, they're looking for that same level of competence and they recognize that each other are doing that good job of assessing the competence.
I just want to mention that although the full license will be transferable, I think that for IMGs, just to understand, there are, because of these provinces have so many licenses and different pathways in each province, our aim is always for the full license, but
Yeah.
you need to find joy and satisfaction in professional fulfillment in the pathway to get to a full license. And it might start as a clinical assistant. And in that way, clinical assistants are not transferable. You can transfer to other provinces, but, I get a lot of IMGs that are, many years without being able to see a patient. And they're like, this is what I trained for. They feel like they are a fish out of the tank. And I'm like, start as a clinical assistant, get back to being around doctors, being around patients. That is your environment. Feel that again, start, practicing again. And then as you engage with patients, you get to know people, you feel more motivated. And there's something about the social learning theory that when you see someone else that is like you and succeeded, you feel like you can succeed as well, and you put more effort, and that is more likely that you're going to succeed. So when you're a clinical assistant and you work with an IMG that is a full independent licensed doctor, and you get to exchange experiences, they might be from the same country as you, they might have a very similar story, and they might be able to share with you experiences that help them, that will help you. So, you need to start. And I think that a lot of MGs, one of the biggest reasons for a gap is not on the medical regulatory authorities. It's not on MCC. A lot of this is a fear of not achieving a full license. You need to give your first step. You need to focus one step at a time. It's like a staircase. Do one thing at a time, focus on one exam, and then move on to maybe a restricted license. But, as you start, new opportunities, new doors will open, and eventually you will be able to progress. And you will progress not only because you are doing the steps necessary, but because you're getting actually clinically more competent. You're improving in your clinical performance, and that's where what will lead to you getting a full independent license. You need to start. If you have a big gap, you need to understand where you can start as a clinical assistant, if you can go back home to break that gap. But you need to get out of that position where, yes, there's a lot to complain, but what can you do about it? And then start taking action today, understanding the process, getting more information, being informed of the possibilities, and then choosing the best possibility for you and actually going after that one step at a time.
Are there obvious things that people can do before leaving their home countries that would minimize the loss of recency of practice?
Yes. So there's a lot of things that you can do before you come to Canada if you're not already in Canada. This is like a crucial thing to understand. I like to mention that, immigrating to Canada as a physician, you need to take in consideration 4 pillars. There's 4 crucial areas that need to happen at the same time. I like to say it's like a chair that if you lose one of the legs, you will collapse. So you need to understand about immigration, and we're not here to talk about immigration today, but you do need to take that into consideration. And a lot of people can apply for permanent residency or provincial nomination programs from their home country, and they don't know about it. So, there's currently on the Express Entry program a category-based selection that will assist healthcare professionals with a lower, decrease the cutoff. But that currently a lot of people are not aware that it exists, for example. So you can apply for immigration, different patterns of immigration, or different opportunities of immigration from back home. The second thing, which is crucial, is language. So that's another huge pattern. You need to, one of the huge pillars. You need to be able to be fluent in the language that you want to practice medicine. And that is anywhere in the world. It's not Canada. I can't go to any other country where I can't speak the language of my patients, right? So I think that is a requirement that is common sense that is required, and that I think that you can take those English proficiency exams and test back home. And one of the proficiency exams that is not as well known is the CELPEEP. And I think that the CELPEEP is a good one for IMGs because it helps, it is accepted by all medical regulatory authorities. That is one thing the FEMRAC was able to make standard across Canada, which is the English requirements. So if you meet CELPEEP, CBL 9 or higher in each area, you're able to practice medicine across the board in Canada when it comes to language requirements. So you can do now CELPEEP across the world. There's many institutions outside of Canada that will offer CELPEEP at their testing centers. So aside from immigration and language testing or proficiency, the third pillar is gap. So staying current, and by staying in your home country, you're keeping your currency of practice, right? So you don't want to come too early to Canada when you're going to have to be studying for exams when you can't practice here. So you want to stay where you can practice and keep your practice active, your competencies at a high level before you can come to Canada, and then decrease that time out of practice. And then the last one is the actual medical license. So the 4 pillars would be immigration, language, the gap, and then the actual medical license. And then the medical license is where the pathways come to place. But we can't start talking about pathways and all these other 3 categories are not addressed, because then you have people that come here and would be eligible for a license, but if they don't have a PR, they don't speak English, and they have a gap of 10 years, unfortunately, the end result will not be what they desire. So back home, what you can do is you can start taking QE1 across the world nowadays. There's many prometric centers that allow you to take the QE1 in your home country. You can take your language test back at home country, and you can apply and wait for immigration results from back home. And when you're ready, you can even start certain application process for the medical licensing from back home. So one of the things that, for example, Saskatchewan stands out in their practice ready assessment program is that they have a pathway for people that don't have the permanent residency. So if immigration and licensing are your last 2 problems, you have the gap and you have the language, you don't have a gap and you have a good proficiency of language proficiency, you pass your exams, Saskatchewan will help you in terms of getting provincial nomination and stuff like that. So there are solutions in many provinces, but there's a lot that can be done before you come to Canada. And one of the things that happens is people come to Canada and sometimes engage into colleges or other jobs to be able to progress to PR. And when they get the PR, they're out of practice. So it's like you try to get one thing and then you lose the other. But some of them are unaware of how they would otherwise be eligible for certain immigration pathways, because that is also complicated. That is also, there are also provincial nomination. So, trying to understand immigration patterns, we're not here to talk about that, but that is something that you need to do your own research and try to find pathways that work for you. And many of those pathways you are able to start before you come to Canada. And the most successful IMGs that I have seen coming to Canada and starting requirements right away, right after they land and get their PR, or they planned years ahead. They come to Canada like 3 years after they have already been planning, taking exams, the QE1. They came to Canada, took NAC, went back home to keep currency of practice. They took their English proficiency exams. They applied for PR, came, did the landing, got their permanent residency. When they match on CARMs and they come, they sometimes have no gap. And you'll say, like, a lot of people say, how's that possible? That's a lot of planning. That's a lot of, anticipating. And I think that is in medicine, anticipating, and Viren is also an anesthesiologist, is part of a non-technical skill. So you don't need to be a doctor to plan well, but it changes the outcome. And doctors need to plan well, need to anticipate potential things that can go wrong. And one of the things you can do is to plan very well the pathway that you're going to choose and what you can do before you get here. And if you're here, you need to organize and create a timeline to decrease the amount of time that you're out of practice. And that is the #1 advice that I can give to IMGs.
Amazing. Thank you. Stephanie, did you want to weigh in about any of that? Maybe a little more on, we're getting a lot of questions about language testing and language requirements. Do you have anything you want to add?
Sure. So language testing, I mean, is required for some sort of obvious reasons, right? You need to be able to communicate with your patients, which is more sort of a conversational language skill. And then you also need to be able to communicate with other people in the medical profession, doctors and others. So those are your sort of technical communication skills. And those are the two things that the MRAs, when they're looking at competence, want to ensure that you have competence to do those two kinds of communication. They use a number of different tests, as Filipe was mentioning. And in general, they are looking for that test to be fairly recent. So this goes to your comments about planning. They're looking for a test that was completed in the last 2 years, although there are some, and this is the whole various pathways things, but if you have been living in Canada, working in Canada, and working in the same language where you have your test results, often that 2 years can be a longer period of time.
Okay, that's really helpful. Okay, we have about just over 15 minutes left in this call, and we have many, 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 many questions. There are.
And we only have one question left? No.
So Vern, sorry, you've been quiet. Do you want to jump in on anything
No.
we've been talking about, or no, you're
No,
good?
no. The experts have spoken on those.
Well, what I want to get to, another thing that I see a lot of people talking about in the chat is we're getting specialists looking for direction. So do you guys have any sort of advice for any specialist trained doctors looking at alternate pathways? Filipe, you are nodding, the hearts are flying.
Okay.
So what do you advise for specialists who may have already had a practice in their home country?
Okay.
Well,
So
let me start and then Filipe
Yeah.
will give the details. I mean, obviously Filipe and I are both specialists, so we kind of know some of these pathways a bit better, or have experienced these pathways per se. I think one of the challenges right now, particularly as we started this conversation about opportunity, is you can imagine there are some specialties more in need than others, and that's just the reality. And so sometimes as we see the emergence of pathways, whether they'll be available for all specialties or the specialties in need or there'll be more focus on the specialties in need. And I don't think it will surprise anyone to hear that, we have need for mental health in Canada, so psychiatrists, internal medicine, with an aging population, geriatrics, and actually Filipe and my specialty is actually a specialty in need, anesthesia, because well, we don't like to pretend we're the most important doctors, but basically there is no surgery without the anesthesiologists, right? And so it has impacted surgical care. The reality is that for the bulk of the for a long time, the major route was repeating residency, or getting essentially Royal College eligibility through either the practice eligibility route, which we spoke about, but we also are seeing the emergence of practice ready assessment routes, including those provinces that I spoke about, Manitoba, Quebec, and Alberta, all having specialist PRA routes, whereby essentially the regulator has deemed that the person is eligible for some sort of license, and in that pathway can again nominate the person forward for a Royal College examination, or will continue the person on license. And as I'll turn to Stephanie, there are discussions about whether those provisional licenses eventually transition to something of increased responsibility through the practice ready assessments. I think where we're continuing to move in this is really how do we, as Filipe has spoken about eloquently throughout this entire thing, how do we meet the requirements potentially of the Royal College so that a person can have the practice eligibility. That includes their training being assessed as substantially equivalent. And I think some of this is also on us to, training can look very different in different countries. And sometimes it's not that the substantially equivalent training hasn't been achieved, or the substantially equivalent experiences haven't been achieved, but they need to be explained so that the credentialing can match what the credentialing requirements are at the Royal College, as well as for any regulator that is in this space. So we're working with specialists, and again, and we're working with the Royal College as well, so that we can work synergistically, so that if we're doing the credentialing here, that we're passing that on, and wherever we can work together in this space, we're moving in that space. Stephanie, I don't know if you want to comment, and then Filipe is the real expert here.
I'm going to go straight to Filipe in the interest of time. He's going to have a lot more relevant stuff to say than I will.
So I just want to say that when it comes to specialists, the changes have been humongous in the last 3 or 4 years. From when I arrived in 2017 and when I got my academic license in 2019, so many changes have happened. I think that right now for specialists, there's a few things that you need to take in consideration. One is the main thing that the Royal College is looking at is your training. So when you think about, the PER process, and people ask me, what is the PER? So the PER is when a foreign doctor that did residency abroad ask the Royal College permission, basically, to sit the Royal College exams in their specialty. This has nothing to do with the medical regulatory authorities. The Royal College has no authority to issue a license. They're a certifying body just like the MCC. However, the medical regulatory authorities rely on them for certain decisions that they make. And then certain process that happen at the high level, national level at the Royal College in different parts of this PR process may be used by different provinces in different ways. So the PR process is a 3-stage process where 1, you ask permission to sit the board exam, 2, you actually take the exams, and then 3, you're actually certified as being a specialist in Canada. So you have 3 steps, and the last step, certification, with the MCC, with the licentiate of the Medical Council of Canada, will lead to full licensure in any province. But there's many different licenses before that. So, in the Atlantic, if you get the eligibility, which means that the Royal College assessed your training, and they're looking only at the training, the duration of training, the quality of the training, and the rotations you did during your training. And if it matches with what is expected of a Canadian specialist, they will grant you the authorization to write the board exam. Even if you never worked in Canada, you might be even applying from abroad. So there's another thing you can do before you even come to Canada, which wasn't possible in 2021. So now it's possible, and it's been a huge change. So I have many IMGs that I know that got the eligibility and were able to start their practice under a supervised independent practice license in Nova Scotia or New Brunswick or Newfoundland or PI. And they're taking the examinations of the Royal College while also collecting the 2-year requirement that they need in Canada. And this requirement, again, doesn't come out of nowhere. You need to be able to practice in a certain place, a certain culture, to be able to be competent and completely independent, providing care in that population. As I said, I can't go to China and just decide that I want to be a doctor there, and it has nothing to do with my ability of knowing medicine. There's so many other factors at play here. So, this 2-year requirement is to ensure that specialists that are well trained, because they got the eligibility, that have knowledge, they passed the exams, they also have the knowledge of the population and the culture of the institutions they work for and the patients they care for. So it is important. I think the whole process is very, very well thought through. And this ability that the specialists have now to request eligibility, to challenge these exams without even being in Canada has been a game changer. So nowadays, as a specialist, you can apply for the eligibility from your home country, which if you get the eligibility, which means that the Royal College understands that your training is at level with what is expected in Canada. And then you meet the language proficiency requirements. You meet the immigration requirements to work and live in Canada like any other citizen in Canada, not only physicians. And then you apply for a job in one of the provinces that recognize that eligibility, you can start working. I do think that for a lot of physicians, the main entry door in Canada is a fellowship. And the reason for that is because fellowships provide further training for people that are already specialists in their home country. And Canada, very different from the United States, is very welcoming of IMGs for a fellowship, in the sense that you don't need to do any examination for most of the fellowship positions in Canada. So you're able to come, you're able to learn, get experience from very experienced, academics in like high level universities such as University of Ottawa, University of Toronto, or any other Canadian university, learn from them, while you didn't really have to do any examination. Doesn't mean you don't have to have any credential. You need to be a specialist back home. You need to have your medical degree. You need to speak English. There's a selection process of who gets selected for a fellowship. But while you are in the fellowship, you already start your transition to practice in Canada, and you start learning to get to know that culture. And last year, the Royal College recognized how that transition to practice happens during the fellowship, that they even consider now 1 year of fellowship to count towards those 2-year requirement of the practice in Canada, which again, the purpose of that is to ensure that you understand the needs of the institution you're going to work for and the patients you're going to care for. So I think that is again another advancement where the Royal College is recognizing how fellowships do provide and do cater to that need, which is, you need to transition, that is correct, but during fellowship that does happen, so let's recognize that. And for specialists that are abroad, I think that they need to understand the value of doing a fellowship is important for continuing medical education. So if you've been away from residency training, you'll be able to update yourself. You'll be able to transition to practice in Canada. You'll be able to be supervised by physicians that provide care for patients that are going to be your patient population, and that will be able to provide reference letters and assess your competency. So when you go to apply for a job in Atlantic provinces, even if you just got eligibility, when you come with a fellowship from Canada or a Canadian institution with reference letters from Canadian physicians, basically you come with an attestation that you're ready to practice for the Canadian population and you're at level with what is expected by the Royal College. So I think that all these rules are excellent, that I think the Royal College is making a very huge advancement. But my 2 cents for specialists is really try to apply for the practice eligibility route if you're eligible for it. Try to apply for fellowships, and there are 2 or 3 provinces that are doing practice ready assessments for specialists. Before it was Alberta, Manitoba, Nova Scotia. Saskatchewan doesn't call it that, but it's basically the same thing. Nova Scotia hasn't done much because of they have been really strong in the PER. But Manitoba is very strong in practice ready assessment. They have years of experience in that route for specialists, and has been a great pathway for subspecialists that sometimes did not do training in Canada and are not eligible for examinations through the Royal College because they don't have enough years or don't meet the criteria for their primary specialty. So Manitoba has been a very welcoming province for that, for those IMGs. So I think there are many pathways. And finally, just finally, but last but not least, is there are opportunities for people that are more involved in research, that want to be in academic centers to pursue an academic license. That's how I started. And after you start doing a fellowship, you get engaged into research, and you want to be, help medical students, residents, and fellowships, and your fellows, and you are interested in helping to train the the new generation of physicians. You're able to also practice medicine under that license.
And I'll just
all
add
right.
Quebec to your list of provinces. So Quebec is another one that will do specialist work.
Okay. I am mindful of the time and there's so many questions. One thing we haven't addressed clearly, I think, for our audience is the difference between, and Vern, I'm going to get you to take this, the difference between IMGs, so IMGs and ITPs who have different backgrounds. Can you just very quickly make sure everybody understands what we're
I
talking
think
about?
that most of our 2,000 plus people on this call are actually internationally trained physicians, and I'm sure Filipe will nod at that. Though, and that's someone who's actually finished their medical school, often finished some sort of graduate training or postgraduate training or residency training, and probably practiced. And I think most of our comments today are about internationally trained physicians, those who are past that. We need to get this nomenclature right because, again, the term IMG is being used in the public eye. IMG is really someone who's just completed medical school in another country, essentially. And as we all know, because we're all physicians on this call, mainly, that we know medical training is much more than just medical school. There's all graduate training and postgraduate training is really where we specialize in any discipline, and our scope of practice narrows. So we're working hard to make sure that you are all represented correctly as internationally trained physicians ready to serve patients in Canada. The international medical graduate, quite frankly, hasn't done any graduate medical training, and that is the candidate who should be going into our residency programs predominantly.
Anyone want to add anything? Filipe, I know you want to. I'm mindful of time. The challenge with this webinar has been that we have a lot of people in the audience, in fact, with lots of a wide scope of experience. And what's clear is that I think we're going to have to do more of these because, as the audience will know, there are many, many, many hundreds of questions in here, and we haven't been able to get to all of them. We've got 4 minutes left to go. And what I'm hoping we can do is leave the audience feeling a bit hopeful, because while there is some sort of enthusiasm in the chat, there's also some discouragement. And I know that we started on a kind of positive note with some positive changes. Is there anything that, as we think about like leaving our audience and they're going back into this sort of trenches of getting working to practice here in Canada, anything we want to leave them with?
Can I start this one?
Yes, you may. Yeah.
Sure. So I think Vern has touched on this already today, but really the reality is that for a long time, if you wanted to practice medicine in Canada, we looked for equivalence. Were you trained exactly the same way for exactly the same amount of time? And would you please go through our pathway of residency and do it exactly our way, because our way is the only way. And I think historically, this wasn't just true in medicine. Honestly, this was true in all the professions in Canada. If you did it exactly the way we did, then that's good enough. And I think that mindset has shifted. And the mindset now is, well, gee, you can become competent in many different ways. The Canadian pathway is not the only pathway. And so now, instead of trying to measure, were you trained exactly the way a Canadian physician was, we're trying to say, are you competent to provide care in Canada? And that changes everything. It changes the whole way that people are trying to design the system and navigate in the system. And I think that mindset is so positive. And that's what matters to a patient, right? They want a competent physician. They want someone who will be with them and have the knowledge and the ability and the ethics to do what they need done. And I'm not a physician. I have no idea what you guys went through to get the designations, the certifications, and all of the training you did. But I know that when we set the bar the right way and look for, do you meet this bar? Then we start to create all those pathways. And they are proliferating. Every meeting I go to, they're having discussions about what's changing. Literally, it is the start of every meeting. So what's new for you? And, people are sharing those new pathways because we need them in Canada. And so that's a good time for new pathways to come up, for these innovations to be accepted and embraced. So there's probably never been a better time to be trying to become licensed in Canada. And I think it is going to improve. People want physicians from all around the world. The population of Canada comes from all around the world, and so should the physicians in Canada.
Great.
Let me go next
yeah,
because
go
I'll just
ahead.
be depressed. I'll be depressed if I see all the hearts that Filipe gets and I don't get as many. So
To be
it's
fair,
no, it's
Stephanie
a
just got
very
a whole
it'll
lot
just
of
send
hearts.
me to my pillow to cry tonight. I also want to thank Stephanie. You know, Stephanie often starts everything saying she's not a physician, but she's done an incredible amount of work in the time that she's been leading FEMRAC, and I would trust Stephanie to give an anesthetic more than she should trust me to build a bridge. I assure you. So all our work in thing. You know, listen, Stephanie said it well, and we've said it many times. I do really hope that people have hope because things are changing. You know, I hope that if we and actually I'm going to do this to the team right now. We are going to commit to doing another one of these, given how successful it was. So, and what I do hope we say is that things aren't just changing daily; they're changing hourly, and that is the reality of the state, the pace of change. I know it doesn't feel like that when you're on the other end of it, but please recognize that many of these structures and policies were glacial and they're finally starting to melt. And I'll just close and I'll leave it with Filipe for the final word is that, you know, I was recently asked in an interview, you know, what's the most surprising or what is the thing that I'm most proud of? And I'll tell you the thing that's I answer to that is how inspiring it is to you know, come out of our ivory tower and talk directly to all of you. I know it's by chat here because I'm inspired that in spite of all of the challenges, you all remain committed to wanting to bring care to patients in Canada. And that inspires me and gets me up every morning and gets me here to try and work for you to figure out these pathways, figure out what's the right thing to do, maintain the patient safety, as Filipe said many times. And all I can tell you is I promise we won't stop until we figure this out.
Right. Over to you, Filipe.
Vern got a lot of hearts, and now I feel bad if I don't get my set of hearts now after he complained. But I want to say to basically to all IMGs that, you know, I'm an IMG myself. I did all my training, most of my training in Brazil. I did my fellowship and then I stayed. But my residency training, my medical school, and my PhD was done back in Brazil. And I want IMGs to see, like, I'm not better than any of you. Like, it's just, you know, there is a pathway for everyone. You need to believe that it's possible. You need to just find what's the best pathway for you. And we all come from different walks of life, and we all have different stories, different specialties, different experiences, and there's a pathway for everyone. And I think each province will be able, you know, the variety that are in the many different provinces has its downside, but it also has the bright side, which is that it provides opportunity for everyone with different backgrounds to have an opportunity here in Canada. I do find that, you know, the change has been happening. It has been at a rapid speed into a way that, you know, and it has not come easily. I'll tell you that. A lot of IMGs has been begging for this for many years. IMGs that came way before me have been asking for these changes, and they're happening. So I think there's a lot of excitement to celebrate. I think there's lots to celebrate. There's a lot of excitement of what's to come. And I think that one of the things that will happen next most rapidly is that transparency in terms of requirements and what are the current regulations for each province. The MCC is working on that. I think the MRAs are working on that and how they can improve their websites, how they can improve their communication into what are the requirements for each province so that, you know, IMGs know at least what are the rules at play so that they know where to invest their time and effort. And I think that is the very first step that we need to do forward, and then continue evolving. As Stephanie mentioned, every meeting they're trying to improve. And I'm sure that, you know, all the medical regulatory authorities have at their best interest patient care. And that aligns with physicians. That's what we do. We provide patient care. So I think we're all aligned into our goals. It's just a matter of where we meet in terms of like standards, efforts, examinations, and requirements. And I think that by providing a more transparent, you know, or making those requirements more easily available will be a great start. And I think that the IMGs have a lot to look forward for.
Amazing. Thank you so much. We've gone over by a couple minutes. What I want to say to the audience as the moderator is we see your questions, we hear your concerns, and they will inform the kind of communication that we put out going forward. So if you didn't hear your question answered, don't worry, we know we've heard you. So thank you so much for taking the time to ask questions and to converse in the chat. It's been really fantastic. For those of you who are asking, you will be getting a recording of this webinar in your inbox. You'll be getting it very, very soon. For those of you looking for the French version, un enregistrement avec traduction en français sera disponible bientôt et vous sera envoyé par courriel. So I want to thank everybody who participated today. Our audience, thank you. You've been fantastic. Our Dr. Naik, Stephanie, Dr. Santos, thank you so much. We really couldn't have done this without you. And a special thanks to all of the MCC staff and other people in the building who've been helping out in getting us to this, our very first webinar. So, and as Vern just said, not our last. So thanks very much, everybody. Go off into the world and enjoy the day. And we'll be in touch soon.
Thank you.
Bye.
Thank you.